Hi, I want to talk about Hellp syndrome. Hellp syndrome. Well, it might sound funny that HELLP has a syndrome. Well, some women will understand, but everyone can get a clearer picture by the time I'm done. Okay, let's go. Hellp syndrome stands for H. hemolysis, EL elevated liver enzymes, LP low platelets. So when I started with Hellp syndrome, and I stressed the point that someone could be confused, why will HELLP have a syndrome? Well, the meaning is now here. It's not just helping someone. It's a serious problem in pregnancy, and it stands for hemolysis, elevated liver enzymes, and low platelets. So three troubles at the same time. This syndrome is found in pregnant and postpartum women. Some regard it as a severe form of pre-eclampsia. However, some believe that it is a separate entity. Why that? Because some of the pregnant women with Hellp syndrome don't actually have proteinuria or hypertension that could be found in pre-eclampsia. So this is the line that defines Hellp syndrome from severe pre-eclampsia. In the past, we regarded the features of Hellp syndrome to be a kind of severe pre-eclampsia, but it is now discovered that not all pregnant women who come down with Hellp syndrome actually have proteinuria or hypertension. And you can make the diagnosis of preeclampsia without proteinuria. So I'm going to make a separate presentation on preeclampsia very soon. You can watch out for that. But for today, let's continue with Hellp syndrome. It is found in 1% of all pregnant women. Without preeclampsia, Hellp syndrome is possible. 1% of pregnant women, mostly white women, 25 years or older. That is not to say only white women could have it. It's worldwide. Anybody could have it, but it's more common among white women at 25 years old or older than that. What are the risk factors? Increased weight, increased body mass index. A woman who had Hellp syndrome in the past, now pregnant, there's possibility of reoccurrence. Previous history of preeclampsia, like I've said just a while ago, that some even categorize Hellp syndrome as a form of severe preeclampsia. So if someone had preeclampsia in previous pregnancies, or at least one pregnancy in the past, and now developing Hellp syndrome, we can link that together. And non-specific genetic roles. Genetic roles would have some play, some roles here, but it's not specific. Antiphospholipid syndrome increases the chances. Okay, now let's get down to each of the three components that constitute Hellp syndrome. The pathophysiology of all the three components. The hemolysis. Why the breakdown of the blood cells? Okay, that is secondary to high angiopathies when red blood cells travel through the damaged endothelium and large fibrin networks. So when the passage for red blood cells, the endothelium around lifeline is damaged, and there are a lot of fibrin networks. It will break the red blood cells. That's why we have that hemolysis. Why the elevated liver enzymes then? Okay, that is secondary to microvascular fibrin deposition. So the fibrin will be deposited in the liver, then there will be neutrophilic infiltration along with fatty infiltration. Then necrosis will occur with hemorrhage. The liver is damaged right now, and that will lead to sinusoid obstruction. When they are obstructed, they have a vascular congestion. And when we have vascular congestion, there is intrahepatic pressure. Tumor necrosis factor alpha will be released, and that will lead to the release of liver enzymes. So the enzymes are elevated. Why the low platelets? It is secondary to thrombotic microangiopathies. Why? It is because the platelets are exposed to von Willebrand factor due to its increased concentration. Then the question is, why would the von Willebrand factor be increased? It is increased largely due to decreased degradation proteins that are already lost in urine. Like I've said, in pre-eclampsia, people will have proteinuria. So in Hellp syndrome, which is very close to severe pre-eclampsia, and it could be a feature of pre-eclampsia in a woman with pre-eclampsia or on its own as an entity. But the feature here is that proteinuria will involve some proteins that are responsible for degradation of von Willebrand factor. So we have low level of those proteins. In other words, von Willebrand factor will be in high concentration because they are not being degraded. And when they are in high concentration, that is von Willebrand factors, then thrombosis will occur. The platelets will be able to aggregate the more. What are the clinical features? Needless to say that this will occur in a pregnant woman. Well, it's not a laughing matter to the affected women. Well, it's going to be a problem of a pregnant woman. Mostly at second or third trimester between 28 to 36 weeks gestational age. It is rapid onset. It means it occurs fast and progressively worsen. There will be pain, and the pain will be limited to the epigastric region or the right upper quadrant and will be waxing and waning, meaning it's colic in nature. There is possibility of hypertension, but not in all cases, nausea, vomiting, malaise, and headache. Possibility of blurred vision and retinal detachment. Ascites from the liver damage, jaundice from both the liver damage and hemolysis. The hemolysis will give unconjugated, while the liver problem will give conjugated bilirubin. Disseminated intravascular coagulopathy, abruptio placenta, particularly when there is associated high level of blood pressure, hypertension. Acute kidney injury, with or without proteinuria. Like I've said earlier, some women with Hellp syndrome may not have proteinuria, and that is why it's difficult to say categorically it is a form of pre-eclampsia. Why some will do have proteinuria. Possibility of pulmonary edema with wheezing, coughing, and you pick down auscultation. Massive bleeding. Of course, when we are dealing with thrombocytopenia, we should expect bleeding. So when there is massive bleeding, they have associated dizziness, tiredness, lightheadedness, palpitation, because the heart will be pumping faster to meet up with the requirement. Now there is anemia. There will be pallor, decreased level of urine production called oliguria, or complete shutdown, anuria. And that's why I said acute kidney injury earlier. How do you make diagnosis of Hellp syndrome? After all pregnant women are pregnant. Then how will you know this is Hellp syndrome? At the time we take complete blood count, we'll know, and we'll do our blood group and rhesus factor in this woman. Platelet count will be less than 100,000 cubic millimeter. Platelets count, I will know that. Peripheral smear will show signs of hemolysis, stocysts and ball cells, while liver enzymes will show that there is problem and they'll be raised. AST, ALT, LDH. When you do liver function tests, there's possibility of high level of bilirubin, INR, APT, albumin, and low albumin, and low glucose because liver function is impaired. Serum aptoglobin will be low. And when serum aptoglobin is low, that shows that there's ongoing intravascular hemolysis. I will explain more about aptoglobin in a bit. Blood urea nitrogen, we want to know with creatinine, know what is going on in the kidney there. And because I've just said that it's likely the woman will come down with acute kidney injury, oliguria, or anuria. Electrolytes, uric acid will be increased. And ultrasound will be required here for fetal well-being because that will determine what we do, whether the delivery will be immediate or we can still afford 48 hours depending on gestational age and the fetal well-being. And of course, the well-being of the mother as well. Now, aptoglobin. Aptoglobin is decreased when there is intravascular hemolysis. Why that? Aptoglobin is expected to be binding free hemoglobin. So when the value is less than 225 milligram DL or LDH greater than or equal to 2 times the upper limit, they are pointing to severe hemolysis going on. It means a lot of hemoglobins have been released, and aptoglobin binding to those free hemoglobin has consumed the level of aptoglobin. So when the level is high, it means there's less free hemoglobin because the concentration of aptoglobin is inversely proportional to the level of hemoglobin. So when aptoglobin has been used up because we have more free hemoglobin, secondary to intravascular hemolysis, the level of aptoglobin would drop. LDH is, however, non-specific. What are the possible differential diagnoses here? AFLP, that is acute fatty liver or pregnancy. Why? Because we are dealing with liver enzymes that are raised. So there will be increased white blood cells if it is acute fatty liver of pregnancy, with creatinine and acid level will all be raised. Platelets will be down, fibrinogen will be down, and the individual will be bleeding. So it will give a picture, live, that of Hellp syndrome. Hemolytic uremic syndrome will give similar picture, and thrombotic thrombocytopenic purpura. Pre-eclampsia, like I've said, particularly severe pre-eclampsia will give similar picture, or some call severe pre-eclampsia fulminant pre-eclampsia. It could be hyperemesis gravidarum, and if that is the case, there is possibility of increased ALT and AST. So what is going on? Liver enzymes are raised, yes, but it's not Hellp syndrome yet because you won't find the rest features. It is possible this might be intrahepatic cholestasis of pregnancy. What will you see then? Increased bile acids, and that will lead to itching. Mostly the palms and soles will be the areas that will be first affected, and the woman will be complaining about them. Bilirubin will be raised also. You remember in Hellp syndrome, it's possible to find jaundice. And of course, liver enzymes are raised. So it's not in all cases that liver enzymes are raised that is Hellp syndrome, but in Hellp syndrome, liver enzymes will be raised. And it's possible this is systemic lupus erythematosus, which is an autoimmune condition. And when you find one autoimmune condition, you might find the rest or another. Treatment. Treatment is not one-way traffic. We need to review the ultrasound results, that is the gestational age and the fetal well-being, and of course the well-being of the mother. We'll go over the laboratory result and see how badly damaged the system is, how low the platelet is, how badly damaged the liver is, and to what extent is the hemolysis. Then we're going to do a thorough physical examination because we're not going to treat only the ultrasound and laboratory, we are treating human beings. So if lab is even giving us good values, which could be human error sometimes, but the human being we're dealing with, the potential model is not stable, that would dictate what we do immediately. Then the second step is to stabilize the mother. The mother is the most important person out of these two people involved, or even more if it's multiple gestation. So we admit this woman right now, check the airway for any foreign body or secretion, remove the foreign body or suction as may be appropriate. Check the breathing, any respiratory distress, any central cyanosis, peripheral cyanosis, any deformity of the chest region, using of accessory muscles of respiration, count the respiratory rate, pause for dullness, or auscultate for wheezing or any feature of pulmonary edema, crackles. We're going to do something about circulatory system, check the blood pressure, the vital signs generally, that's the pulse rate, the blood pressure, the hydration level, put our IV fluid on, pass catheter to no fluid in and out, and then determine whether or not the mother and the baby are stable, because that will determine what we'll do next. Okay, we're going to put our IV fluid up with or without glucose, depending. Then cardiac monitoring, blood pressure control. If the blood pressure is very high, we have few medications to use. Hydralazine or labetalol are safe and could be given intravenously, but very slowly. As a matter of fact, we give hydralazine very, very slowly. Some will even put it in the IV fluid. Magnesium sulfate could be used for prophylaxis against seizures. You know, like I've said in the beginning, Some categorize Hellp syndrome as a component of pre-eclampsia, specifically severe pre-eclampsia, which means before eclampsia. And eclampsia means seizures or convulsions. So you don't want to get to that level, so magnesium sulfate is administered. I'm going to characterize this woman. She won't be walking around. Bladder catheterization, group and cross match, because you might need transfusion, particularly if there's massive bleeding already. Okay, the third thing to do, not a matter of timing, but just to put everything in order, is emergency delivery. And I repeat, emergency delivery. No matter how we go about it, we are going to deliver this baby because that is the cure. And cesarean section is favored. Why? You don't want to subject this baby that is likely going to be premature to another stress again. So, with the help of the ultrasound that you've taken, and if this woman is the type who has been consistent with antenatal visit, you'll be able to make the gestational age determination quickly. Because if you have not known the gestational age before now, the ultrasound taken now, the second trimester or third trimester, will not be so accurate. Okay? But if you are sure of the gestational age from beginning, then making the determination of gestational age today will not be a problem. Okay? That being said, the gestational age is 34 weeks or greater. Great. We're going to deliver right now, cesarean section. The other scenario is not yet 34 weeks or just a little bit less than 34 weeks. But there are other associated problems like acute kidney injury, disseminated intravascular coagulopathy, aborted placenta, or unfortunately, the baby has even died in utero. Then we are delivering right now. Another scenario is this is less than 34 weeks and there is no problem with the mom or the fetus. In other words, no life-threatening conditions in either of them. You can wait for 48 hours before cesarean section. What will you be doing within those 48 hours? We want the lung to be more formed. We want to help in pulmonary system development by giving betamethasone for the next 48 hours. And after that, we're going to deliver the baby. However, while waiting for more lung maturity with the help of betamethasone, if the fetus or the mother becomes unstable, you stop waiting. Go straight to the delivery room and get the baby out, and there will be a cure. We are going to repeat all laboratory tests after 48 hours post-delivery. Less than 10% will reoccur. Death may occur in less than 1%. In conclusion, if there is prompt presentation, early diagnosis will be made. If early diagnosis is made, appropriate interventions will follow. And with that, we will all have good outcome. The doctors, the nurses, the mother, and the new baby. So I'm wishing all the affected mothers well. Kindly present on time, let the appropriate diagnosis be made quickly so that interventions will follow immediately and we will all be happy. Kindly subscribe to my channel so that you can get these publications immediately they are released. Thank you.